Hey, you beautiful people. I welcome you all to my channel. Today, I will be talking on membranous nephropathy. Let's just study together and jot down our points on the membranous nephropathy. This is also a short topic, and I hope you guys enjoy this video. Okay, so we start with the first thing first. That is the what is the age group? Now, this is something which is 30 to 50 years. Okay. Now, I did study it from Marrow as well. So that says that it is more than that of the 60 years. So it is like a old age uh, disease, right? Now, most commonly male to female ratio is say 2:1. Okay. So now what are the causative factors? Okay. So it is like, I hope you can all see the video, see the box. Membranous glomerulonephritis, that is a primary one, and then we go with the secondary membranous glomerulonephritis. Okay. So now the first thing is the infection, that is hepatitis B, C, syphilis, malaria, schistosomiasis, leprosy, filariasis. This is very important. All the points are very important. The next thing is the breast, colon, lung, stomach, kidney, esophagus, cancer, neuroblastoma. Drugs like gold, mercury, penicillamine, NSAIDs, probenecid, this is also very important. Autoimmune diseases like SLE is important, rheumatoid arthritis is important, primary biliary cirrhosis is there, dermatitis herpetiformis, bullous pemphigoid, myasthenia gravis, Sjogren's, and Hashimoto's thyroiditis is also very important. Then other things is the diabetes, Guillain-Barré syndrome, Crohn's disease, sarcoidosis, sickle cell, IgG4 disease. Okay, so these are certain causative factors which are attributing to membranous nephropathy. So there would be a uniform thickening of the basement membrane along with the peripheral capillary loops. Okay, so there is a diffuse granular deposits of IgG with that of C3. Okay, and there is a subepithelial deposits. So degree of tubular atrophy and the interstitial fibrosis. This is predictive of the whatever the fibrosis is, the progression of the diseases. So this is very important. Okay. Now the subepithelial deposits are seen in also the membranous lupus nephritis. Okay, so now this is very important. The antigens are asked frequently in INI exams. So one is the megalin, then is the neutral endopeptidase. The bovine serum albumin is there. Phospholipase A2 receptor. This most of people have heard this word. And thrombospondin is also there. So it is the 70% of the individual they have a phospholipase A2 receptor antibodies. Okay. So again, the target antigen, phospholipase A2 receptor, anti-thrombospondin, anti-semaphone 3B. Okay, this is not being asked anywhere, but this is a potential topic. Then anti-NEP, antenatal membranous nephropathy. This is an intrinsic antigen. If we are talking about the extrinsic, this is the bovine serum that can be asked. Okay. The next thing is, now whatever the circulating antibodies would be there, and the glomerular deposits, that would be directly proportional with the spontaneous remission is there or not, severity of the membranous nephropathy, and the response to the treatment as well. So the 80% of the patient, they present as a nephrotic syndrome, and they have a non-selective proteinuria. There is a microscopic hematuria, which is less common, but it could happen, right? And there could be a spontaneous remission in almost like 30% of the individuals. So this is very important. One third can go into remission, one third can go into heavy proteinuria, and one third can have a end-stage renal disease also. Okay, so when do we treat the patient? If the patient has a nephrotic syndrome, if there is a nephrotic proteinuria in say 6 months with a normal GFR, and if there is a non-nephrotic proteinuria but there is increase in creatinine, then we can go with the treatment. There is a modified Ponticelli regimen. I hope that everyone is thorough with this. We give the prednisolone to such patients with the oral cyclophosphamide, and say if there is no response, rituximab is the rescue one. Okay. So there is this primary membranous nephropathy and there is a secondary membranous nephropathy. So IgG4 disease is IgG4 antibodies are more commonly associated with primary membranous, and IgG1 and IgG3 is more in secondary membranous. Okay. The presence of IgA and IgM is not there in the primary one. Mesangial immunoglobulin staining is also not there in primary membranous. C1q staining would be positive in secondary membranous nephropathy. Okay, phospholipase A2 receptor would be positive, and in primary membranous it is negative in the secondary membranous. Subepithelial deposits, only subepithelial deposits. Okay, here the subepithelial, mesenteric, subendothelial deposits. So you have to remember that in primary membranous nephropathy, only positive thing is the phospholipase A2 receptor. Otherwise, everything is negative, and it is the IgG4-1, and only the subepithelial. Here, everything will be there in case of secondary membranous nephropathy. Okay. So the worst prognosis will be in case of males, older age group. If the patient has hypertension, if there is a persistent nephrotic range proteinuria, then it has a worse prognosis. Now, this is said that there is a high chance of thrombosis in such patient, and that's why we have to think of the antithrombotic factors in such patients. Okay, so prophylactic anticoagulation is to be done because we have already seen that hypoalbuminemia is directly proportional to thrombosis, and this has a patient has a more prone for thrombosis. So there is the highest reported evidences. So we have to go with the antithrombotic anticoagulation. Okay, so we can go for the AC inhibitors. Okay, statin can be used, diuretic can be given, and of course cyclophosphamide, cyclosporin, rituximab, anti-CD20. These are all tried, right? Okay, so that was all about the membranous nephropathy. Now, this topic is very short, but yet it is very important because most of the MCQs have been asked on this because of the causes, first of all, okay, and the thrombosis risk, okay. The Ponticelli regimen is also very important, okay. So, thank you for watching.